So let's talk a little bit about this function now, that I think it's most challenging for good part of the therapies, I would say, just because the arrangements are quick and easier to treat, and we see the results, and these functions, you know, that it's a more long-term treatment. So how do you commonly start the treatment, and do you have any insights or tips to our listeners that don't have a lot of experience with this this classification?
Before you even go to treating it, there could be a lot of difficulties with treating that classification because people are not identifying it correctly. You got to make sure this is actually contractile dysfunction before you remodel it, right? So if you're going through the system and you're, let's start from the history then. Okay, if this is a contractile dysfunction, what do you expect to hear? You're gonna, if you start from the top part of the form where you would start with your body diagram, you wouldn't expect there to be, you expect local pain is what I'm saying. You wouldn't expect there to be pain the whole leg, whole thigh and calf, and you wouldn't expect upper arm and forearm pain. You wouldn't expect any tingling. You wouldn't expect it. You wouldn't expect it, although it's possible for it to be bilateral. So you got your first clue there. Then afterwards, in the you're expecting some kind of a overloading mechanism to have occurred. Just contractile dysfunctions don't just pop up out of nowhere. Now, there may be a difference between you knowing that and the patient actually remembering that they overloaded it the day before or something. They might feel like it has occurred for no apparent reason, when in reality, I get this fairly often, that people who train a fair bit, 3-4 times a week, then they take a month or two off, then they go back resuming the same exercise they did 2-3 months ago, and they're wondering why they hurt, because they don't necessarily know that your body adapts to its imposed demands, and as you train, you get stronger, sure, but as you stop training, you also get, I don't know if I would like to say weaker, but yeah, in a sense, your body adapts and grows and hypertrophies, and then it also atrophies as you do less. And they don't necessarily feel that 2-3 months later that they've lost much physical fitness. So they go back and do exactly the same weights as they did before, and then they develop a contractile dysfunction. So I make it a point to ask them, and they tell me, no, this kind of happened for no reason. Okay, so did you, if you trained, did you stop within the last, if they said it's been 3 months, then so 4 months, 5 months before, did you stop for an extended period of time? I think you could get valuable insight from that question. And then you move down in the form, and you start to realize what they're telling you as aggravating factors. Aggravating factors are activities that would load the tendon or the contractile dysfunction, right? They wouldn't just sit there and have it start to be painful. That'd be odd, unless they did a lot of exercise and then they sit after, and then it might be painful at rest for a little bit. That happens, but you wouldn't expect them to just sit there and have it start for no reason. Then you move towards your objective examination. You take a look at their range of motion. If it's contractile dysfunction, you're not expecting much loss there. It would be no loss to minimal loss, and minimal only because you're compressing that whatever affected tissue you're compressing or stretching it. And so the pain that they feel with that, I also make a point to ask them, once I get to the manual muscle testing, let's say it's a shoulder, and we reproduce pain with abduction, for example, resisted abduction, then I would I would ask them, so the pain I'm producing here with this, which one's worse, this one or the one that you feel when I take you to end range flexion, for example? And typically, if it's contractile dysfunction, they would tell you the one where I'm pushing against you. So you paint that whole picture, and then you go, well, local pain only hurts when you load it. There has been an overloading mechanism, no range of motion loss, strength weak and painful. It starts to sound like a contractile dysfunction, you know? So you take that all into consideration, and for sure, it could always be, let's say if it were a shoulder, an upper extremity, then it could also be spine, right? So you check you do your spine screening, repeated movements, but if that's all good and pain-free, what I started doing more lately is that I know you're always trying to rule out derangement, right? Whether it be spinal or extremity. But if I get to that point and with that patient, let's say that I just described, and I've gone through the spine screening, which takes, again, 5-10 minutes, I've started to try to remodel them right away. I know you're doing it by the book. You're going to do repeated movements of the shoulder, for example. You know, we're talking about a shoulder. But I found it to because the thing is with contractile dysfunctions is that if you do repeated movements with them, you may get some minor changes. Sometimes some even derangement-like changes within the session. But those changes don't hold up. And you can't know that on the first day because it looks great, right? But when they go home 2 hours later, it's the same presentation. When they're going to come back and see you in 2 or 3 days, they'll tell you it's about the same.